So today we are going to look at the clinical diagnosis of hemiplegia in terms of localization of the lesion. Because hemiplegia is such a common condition that definitely in the examination you will be asked where is the localization. Hemiplegia, even patients will tell what is the big thing you have to tell. He will come and tell, sir, I am not able to walk on one side of my body is not working. You have to find out where is the lesion. The prognosis obviously depends upon the type of the lesion and the level of the lesion also, isn't it? So hemiplegia is paralysis of one half of the body. It might include face or not, may not include face, plus or minus arm, plus or minus leg. So there are three components: face, arm, and leg. It could be all the three. It could be only face and arm, or it could be leg and arm, or predominantly leg also. Okay, this is because of the interruption of the motor pathway. Okay, so hemiplegia is paralysis of one half of the body, face, arm, and leg, with a combinations of those things. Another thing is acute versus chronic. It could be an acute hemiplegia or it could be a chronic one. It could be flaccid paralysis. It could be spastic paralysis. Presence of facial involvement may be there, may not be there. Sensory, speech, visual, or higher cortical functions are important aspects that you should question. What are the things that you need to focus on? Are there any associated sensory things? Is speech affected? Is there any visual disturbance? Or higher cortical deficits are there? Okay, what are the motor pathways? Let us trace them from the brain down. The primary motor cortex, precentral gyrus, from there it starts. From the precentral gyrus to the corona radiata. From the corona radiata, it converges onto the posterior limb of the internal capsule, then the cerebral peduncle in the midbrain, and then the pons, then in the medulla, pyramids, and finally the pyramidal decussation in the lower ventral medulla, and finally the spinal cord. Through the spinal cord, after crossing, it will go down to the anterior horn cell, which is the lower motor neuron. It's a two-order neuron. One order from the cortex up to the anterior horn cell, and from the anterior horn cell to the muscle is the second order neuron. This all we know. Already we have studied the neuroanatomy. Now, lesions above the decussation, lesions below the decussation. Where is the decussation? Decussation is in the ventral lower medulla. Okay, medulla is divided into rostral and caudal. Caudal medulla. Caudal part of the medulla, ventral lower medulla is the decussation. Any lesion above that side, above that particular area, will produce a contralateral hemiplegia. For example, there is a lesion in the upper medulla on the right side, produces left side hemiplegia. But after the decussation, let's say at the level of foramen magnum or below the decussation, left side lesion produces left side hemiplegia because already the tracts have crossed. That's very important. Ipsilateral below the decussation, contralateral above the decussation. So this is a little bit about the gross view of the brain. The primary red color is the primary motor cortex. The green color is the primary somaesthetic cortex. Somaesthetic is the correct term. You may say sensory cortex. Somaesthetic cortex. It's called somaesthetic cortex. Somatic sensory cortex. Because the visual sensations are not here. The visceral sensations are not here. This is somatic sensations. That's why it's called somaesthetic cortex. So you can see the central gyrus is there. Before the gyrus is the premotor cortex, precentral gyrus, and then next to that is the postcentral. There's a slight difference in the distribution of the body sensations and motor. You see, pharynx is given very great importance as far as the sensations are concerned, separately. Whereas in the tongue and pharynx together are there in this part. Speech and vocalization is a motor function. So it takes a predominant thing. Like that, you see the hand also is given a larger function here. That is because of the special skills that you do with the hand. And there is not much of motor function for the genital region. There's a lot of sensory function for the genital region. So there's some differences are there. That's okay. Stepwise bedside localization. This is a very familiar thing all of you must have known by the tone in upper motor neuron lesion. It is spastic, not rigidity. It is spasticity. Rigidity is a feature of the extrapyramidal syndrome. Spasticity. Whenever you describe hemiplegia, don't say that I am rigid. It's spastic. Upper limb is spastic, lower limb is spastic. If you say rigidity, examiner think that you are going towards the basal ganglia and the other things. So use the word spasticity. Lower motor neuron lesion, tone is hypotonia or atonia, decreased tone. Reflexes are exaggerated in the upper motor neuron lesion. Lower motor neuron lesion, reflexes are reduced. Plantar is extensor, plantar is Babinski there in the upper motor, plantar is flexor in the normal one. Okay, no problem. So most important thing is hypertonia, hyperreflexia, extensor plantar, absent fasciculations is upper motor. Lower motor is hypotonia, hyporeflexia, and then plantar is flexor and fasciculations may be present if lower motor neuron is involved. This we know. Depending on that, we can say whether it is a lower motor involvement or upper motor. Hemiplegia with upper motor signs. Hemiplegia, if you see with upper motor neuron signs, the lesion must be in the brain or in the brainstem or in the spinal cord also. But in spinal cord hemiplegias, usually will have some lower motor neurons because spinal cord already has got the anterior horn cells. So there will be some, this one will be lower motor symptoms also will be associated. Okay. Distribution of weakness. Depending on that, I can decide where is the lesion. Face plus arm plus leg, a very dense hemiplegia. Face plus arm plus leg, very dense hemiplegia means the lesion is in the internal capsule. Posterior limb of the internal capsule is the lesion. Okay, arm more involved than the leg or not, that also you can say. When you are presenting, if you say arm is 3/5 or 2/5, leg is 4/5, then examiner is already knowing that that arm is more than the leg or leg more than the arm. It could be other way. So, which particular part, is it a dense uniform face, arm, leg is involved uniformly, or arm more than leg, or leg more than arm? Is there a facial involvement or no? This will decide the level of the lesion. Pattern. I'm giving you the pattern. So if you phone me up and tell me, sir, I have admitted a patient with hemiplegia, is there facial weakness? Yeah. Then I know already you are already crossed the brainstem. Is there no facial weakness, sir? But face is one side, sir, and have a leg and other side. Oh, he's somewhere in the brainstem. So no face involvement, only hemiplegia, spinal cord. Immediately. Face, arm, leg equally internal capsule. Face plus arm more involved than leg, middle cerebral artery territory. Leg more involved than arm, anterior cerebral artery territory. There is one syndrome artery called the Hübner's artery. The Hübner's artery thrombosis typically produces faciobrachial monoplegia. Face and arm is more involved than the leg. Faciobrachial monoplegia. If you tell me over the phone, sir, lower limbs are all right, sir. Face and upper limb only, oh, it is MCA territory. Immediately I know where I should look for in the MRI. Okay. So depending on the pattern, we can say. Now, cortical versus subcortical localization. Cortical hemiplegia. There are typical features of cortical hemiplegia which you cannot miss. What is cortical hemiplegia? Something involving the cerebral cortex proper. Cerebral cortex is a wide area. It is very rare to get a through and through ischemia of all the area. So it will be patchy. It will not be very dense. That may be upper limbs may be more affected, or lower limbs may be more affected, or face may be more affected, along with the cortical signs. Often partial, often patchy, often not dense, very unequal weakness will be there. Unequal in the sense one part of the body, one half of the body, hands may be more involved compared to legs, or legs may be more involved than the arms, or face may be more. This unequal hemiplegia plus cortical signs will tell me that it is cortical hemiplegia. What are the cortical signs? Aphasia, if it is the dominant hemisphere, the lesion on the left side, left cerebral cortical hemiplegia, aphasia will be there. So immediately I ask you, how is the patient speaking? Is he able to talk? Yes, he is able to normally talk. Little bit of dysarthria is there, but he is not having aphasia. No, so that means it is not in the cortex, or it is in the right side. Okay, hemi-neglect, non-dominant hemisphere. If right side is affected, there will be what is called the hemi-neglect. I'll show you what it is. Seizures are a feature of cortical lesion. Somebody has presented with hemiplegia and seizures, you should look for cortical lesions. Sensory loss, cortical type of sensory loss. Cortical sensations are lost, like fine touch and two-point discrimination and stereognosis are lost. Cortical sensory loss and homonymous hemianopia. So if he has got a hemianopia, so look at the aphasia, hemi-neglect, seizures, sensory loss, hemianopia, immediately my lesion is in the cortex. Why higher cortical signs occur in cortical hemiplegia? We should know. In cortical hemiplegia, the lesion involves not only the primary motor cortex or the precentral gyrus, but also the adjacent associated cortices, which subserve adjacent part of the cortexes, which subserve the language. That's why the aphasia, the spatial awareness, and then praxis, sensory integration, visual perception. Subcortical lesions, example, internal capsule, interrupts with the fibers only and not the cortex. Internal capsule, there is no cortex, only the axons are there. The axons are crushed, the axons are ischemic, so there are no cortical loss of sensations. What are the cortical features now, you tell me, all of you? Language, spatial awareness, hemianopia, then sensory integration, sensory changes are putting my lesion in the cortex. Cortex hemiplegia is not dense, not totally involving one side. It will be either arm may be more, leg may be more, or hand may be more. So, sit down. Subcortical lesions. Now move on to the subcortical lesions. Subcortical lesions are internal capsule, interrupts the fibers only, not the cortical processing. No cortical signs. Higher cortical signs. I am going to give you the higher cortical signs. What are the higher? Definitely you will be asked. What are the higher cortical clinical signs? Is it in the dominant or non-dominant? So if you are right-handed individual, left is the dominant. Left-handed individual, right is the dominant hemisphere. Dominant hemisphere involvement, aphasia, apraxia, and then spatial awareness usually intact, and recognition, Gerstmann syndrome. Recognition is lost. He will not be able to recognize people. There will be aphasia, there will be apraxia, and also there will be spatial awareness is generally not lost. What is spatial awareness? Where are you? Time and space. Time and space orientation is not lost because that is a function of the non-dominant hemisphere. So aphasia, apraxia, and then spatial awareness preserved, recognition lost. That is called the Gerstmann syndrome. Non-dominant hemisphere is involved. There is no speech problem. Usually speech is spared. Constructional apraxia may be there. What is constructional apraxia? What is apraxia? Particularly when the parietal cortex or the frontoparietal lobes are affected, you get the apraxia. Apraxia, difficulty in planning and coordinating muscular movement, like lip, tongue, jaw, necessary for the speech. Apraxia is a difficulty in planning for the speech. What he will do, if you want to ask him to talk something or say something, he will not have the coordination and this one of the lips, tongue, and other things. So there are several types of apraxia, verbal apraxia, or facial apraxia, and then limb kinetic apraxia, constructional apraxia. Constructional apraxia is a feature of the right non-dominant hemisphere. Difficulty in drawing and give him a paper, ask him to draw a square, ask him to draw a circle, ask him to draw a triangle, ask him to draw some numbers, or ask him to write something, he will not be able to do it. That is called the constructional apraxia. Whereas the other apraxia is speech-related apraxia. Okay? Now you understand that? Now you can go back to the class. So constructional apraxia and then neglect and then visuospatial defects. Spatial orientation is lost. He feels as though one half of the body he will not be able to feel. Topographical disorientation, that is topographical. That means where he is, what time it is, he may not know if it is on the non-dominant side. If you have a case of cortical hemiplegia, you will definitely be asked, how do you differentiate between dominant and the non-dominant? That is the table. Aphasia, apraxia, special awareness intact, recognition lost, Gerstmann syndrome. Aphasia is not there, but constructional aphasia, drawing numbers, drawing figures, drawing any drawings will be a constructional aphasia. Neglect and visuospatial defects and topographical orientation. Now, right side hemiplegia plus aphasia means what? Right side hemiplegia I am seeing, patient is not able to speak. That means Broca's area is all affected. Left MCA cortical involved. Middle cerebral artery cortical involved. Okay. Then subcortical hemiplegia. We have moved one step down from the cortex to the subcortex. Subcortex means it is the gateway. The main gateway is the compact highway for the motor fibers. That is the posterior limb of the internal capsule. There, a dense contralateral hemiplegia. What do you mean by dense hemiplegia? Face, arm, and legs are uniformly affected. If it is 3/5, 3/5 here, if there is hypertonia, everywhere it is a dense hemiplegia because they are all available in one place. Exactly, face, arm, and legs are equally affected. Remember, no cortical signs. Absence of cortical signs reduces the lesion to internal capsule. Dense hemiplegia, no cortical signs, is a pure motor stroke. No sensory signs also, because that area posterior part of the internal capsule doesn't contain the sensory fibers also there. Okay, so what are the cortical signs once again? Language, praxis, spatial awareness, recognition. Apraxia, aphasia, spatial awareness intact usually in the dominant, it is lost in the non-dominant. So that you have to remember. If the sensations are affected, speech is affected, spatial orientation is affected, then you are in the cortex. So now we have come, this is pure motor, sudden right hemiplegia, dysarthria, no aphasia. Patient presented with a sudden stroke, right hemiplegia, he has got dysarthria and not aphasia. What is dysarthria? Difficulty in articulating the speech. It is not aphasia. Aphasia means he cannot even construct a speech. He cannot speak even one word. Here he speaks. What is your name? His name is Ramcha. Construct. This is the dysarthria. Whereas he is not able to speak at all is the aphasia. Okay. So where is the lesion? Left internal capsule. Right hemiplegia, left internal capsule. Now we have come to brainstem. So we started with the cortex, it come to the internal capsule. How did I distinguish between them? Hemiplegia is patchy and not uniform in the cortex. There are sensory changes may be there. There may be premotor cortex changes like, apraxia and then the aphasia and the spatial orientation problems and then recognition problems and cortical sensations like, stereognosis, 2-point discrimination, fine touch, these may be lost along with that. Whereas in case of internal capsule, no cortical sensations are there, no aphasia is there, dysarthria may be there, and the hemiplegia is dense and uniform. Now come to the hemiplegias in the brainstem. The golden rule is ipsilateral cranial nerve paralysis, contralateral hemiplegia, you are in the brainstem. If a patient has got an ipsilateral cranial nerve with a contralateral hemiplegia, is a brainstem lesion. This is also called the crossed hemiplegia. Why crossed? Face is affected on one side, limbs are affected on the other side. If you describe a patient has got a left facial involvement and right hemiplegia, I very well know that it is the left brainstem. So brainstem is again midbrain, pons, and medulla. Midbrain, what are the syndromes? We already discussed when we are looking at the midbrain, but anyway, I am summarizing. Weber's syndrome. This is medial midbrain syndrome. Medial means the central part of the midbrain, medial part of the midbrain. What is the vessel affected? Always you must know the vessel affected. PCA, that is a posterior cerebral artery, paramedian branches of the posterior cerebral artery. What is the vessel affected in cortical hemiplegia? Generally, it is the cortical hemiplegia is affected as left MCA, right or left MCA, middle cerebral artery, this one. Whereas when you go to subcortical lesions, it is usually at the internal capsule. There also you can get the middle cerebral artery involvement. Whereas if it comes to the brainstem, you have got the paramedian branches of the posterior cerebral artery, medial midbrain syndrome. The site is the medial midbrain. What is medial midbrain? The cerebral peduncle and the oculomotor fascicles are there. Medial midbrain contains the cerebral peduncle. Cerebral peduncle contains 4 types of tracts. One of the important tracts is the corticospinal tract. So, ipsilateral oculomotor nerve paralysis and contralateral hemiplegia. How do I know oculomotor nerve paralysis? There is ptosis, their pupils are dilated, eye deviated down and out. Why down and out? Because of the unopposed action of the lateral rectus and the inferior oblique. Okay, down and out. Whereas the eye position is down and out, dilated pupils, ptosis, third nerve paralysis. This is on left side, let us say. Right side hemiplegia has got contralateral. Definitely, this is the left medial midbrain syndrome. This is called the Weber syndrome or medial midbrain syndrome. Definitely, you will be asked either in theory or in the clinics. Benedict's syndrome. What is Benedict syndrome? Benedict syndrome, the vessel is paramedian and the short circumferential branches of the PCA. What is now involved? Tegmentum of the midbrain. Tegmentum is and also the red nucleus. Tegmentum is the dorsal part of the midbrain. Earlier we had the medial part of the midbrain. Here it is the dorsal part of the midbrain. What are the symptoms? Ipsilateral third nerve paralysis, contralateral. Because of the red nucleus involvement, you will have tremor, chorea, ataxia, milder absent hemiplegia. If tegmentum is involved, there won't be hemiplegia because in the tegmentum region there are no corticospinal fibers. So what are there? Red nucleus is there. Red nucleus is for coordination. Tremor, chorea, ataxia on the opposite side, and cranial nerve paralysis ipsilateral. Milder absent hemiplegia is a classical Benedict syndrome. Okay, now Claudius syndrome. What is Claudius syndrome? Paramedial branches of the PCA involved, overlap of the Weber's and Benedict's. That means medial midbrain is involved, tegmentum also is involved. Now what will happen? Ipsilateral cranial nerve paralysis, third nerve, contralateral hemiplegia, contralateral ataxia, and tremor. What is Claudius syndrome? Benedict's plus Weber is Claudius syndrome. Where is the lesion? Medial midbrain as well as the tegmentum of the midbrain. Key point, Claude is equal to Weber plus Benedict. Okay, did you get that? Nathaniel syndrome. Nathaniel syndrome is a dorsal midbrain. Earlier we were talking about the medial midbrain. Now we are talking about the dorsal midbrain. Where superior cerebral artery is the supplier or dorsal PCA branches. Tectum. So the one above the tegmentum is the tectum. So what are the parts of midbrain? These are the peduncles of the ventral part. Then is the substantia nigra. Then the tegmentum. Above that is the tectum. Tectum is the dorsalmost part. Okay. very close to the cerebral apex. So superior cerebellar peduncle or the tectum are inward. What will happen? Ipsilateral third nerve paralysis, ipsilateral cerebellar ataxia, because cerebellar peduncle is affected and often associated with the pineal, because pineal gland is very close to that, or tectal lesions. So if I have cerebellar ataxia on the same side, third nerve paralysis on the same side, no hemiplegia, no crossed hemiplegia, no tremor or other red nucleus involvement, it is a case of Nathaniel syndrome or dorsal midbrain syndrome. Now, nobody has told me like this when I was a postgraduate, all the things in one go. Okay, Perinard syndrome. What is Perinard syndrome? Dorsal midbrain syndrome, which may be vascular, may be compressive, included for completeness, not always vascular. Perinard syndrome is not a vascular disease, mostly compressive disease. Why I have included here? Just to complete the syndromes. Dorsal PCA branches are a compression on the dorsal medulla, pretectal area, and superior colliculus. Superior colliculus is involved with the gauge, so upward gauge policy will be there. So there will be lid retraction. This is called the Collier sign, and convergence and retraction nystagmus will be there. They are more related to the superior collicular function. So now you tell me what are the 5 syndromes. That's all. We go to the pons now. Okay? No. I'm asking you one by one. You tell me one by one. I have closed that. Claudius, the first one is the medial midbrain syndrome or Weber syndrome. What will be there? Third nerve paralysis, ipsilateral. Third nerve means what? Pupil, and then deviation of the eye downward. That's all. Deviation of eye down and out, pupil is not reacting, and then the ptosis is there. Because the third nerve, contralateral hemiplegia. This is where must go. Where is the lesion? Medial midbrain, which is the artery, paramedial branches of the PCA. Okay. Benedict's syndrome is, this is more and more for the coordination, red nucleus part. That's ipsilateral third nerve, contralateral tremor, chorea, and ataxia. Okay. So hemiplegia may not be there because the corticospinal fibers are not there. Where is the lesion? The lesion is in the tegmentum of the midbrain. Peduncles, tegmentum, tectum. So the middle part of this one is this one. So the one separates the peduncle and the tegmentum is the substantia nigra. After the substantia, tegmentum. After the tegmentum, cerebral aqueduct, and then the tectum. Tectum is the dorsal part. Okay, I have already showed you those diagrams. So ipsilateral third nerve paralysis, contralateral tremor, chorea, and ataxia. Whereas there are red nucleus functions. These are the coordination problems. So that occurs in case of Benedict syndrome. Then comes what is the next one? Claudius syndrome. What is Claudius syndrome? Combine both. Combine Weber into this. So you have contralateral hemiplegia, contralateral tremor, and all the other things. Ipsilateral cranial paralysis. So the lesion is again paramedian branches of the posterior cerebral. Nathaniel syndrome. Third nerve paralysis, contralateral cerebellar. Ipsilateral cerebellar and ipsilateral third nerve paralysis. Maybe some pineal lesion also may be there. Perinard syndrome. Perinard syndrome is more a compressive disorder. It is at the level of the superior colliculus. Vertical gaze policy, and then lid retraction problem, convergence nystagmus, all those things occur. Okay. Now we have come down from where? It started in the cortex. Our journey started in the motor cortex. From the motor cortex, we came to the internal capsule. Then we came to the midbrain. Now we have come to the pons, pontine hemiplegia. Okay, which is the most important motor nucleus in the pons? Facial now. So ipsilateral lower motor neuron type of facial paralysis. It is not upper motor neuron, not like Bell's palsy. What is the difference between lower motor and upper motor in the face? Lower motor neuron, upper motor neuron of the face means only the lower face is affected, upper face is not. Why upper face is not affected? bilaterally innervated. Whereas lower motor neuron means whole of the space. So Bell's palsy is only the face is affected. Here contralateral hemiplegia is there. If you see a patient with lower motor neuron facial paralysis, immediately look for the hemiplegia on the opposite side. If it is not there, he is saved. It is not a pontine lesion. It is only a peripheral lesion. If he has got hemiplegia also on the opposite, pontine lesion. And possibly gauge palsy also may be there. Why gauge palsy in case of pontine lesion? Because of the medial longitudinal vesicles. Then medial vesicles is the one gauge problem, not that one which goes all those things. So now localization. Now come to the various syndromes. What are the vascular syndromes of the pons? This can be a question. Ventral pons, Maillard Gobler syndrome. Ventral pons, Maillard Gobler syndrome, ventral pontine lesion involving the corticospinal tract and facial nerve fibers, ipsilateral lower motor neuron paralysis, and contralateral hemiparesis. Ipsilateral LMN, lower motor neuron type, means involving the whole of the face. Okay? And lower motor neuron, not only the whole of the face, there will be wasting, there will be fibrillation, there could be fasciculations on the face also. That is sign of lower motor neuron. Fasciculations, fibrillations, wasting, lower motor neuron type of facial paralysis involving the whole of the face. Contralateral hemiplegia. That is the lower ventral pontine lesion, which is called the Maillard Gobler syndrome. Fauvel's syndrome. Fauvel's syndrome is lesions involving the PPRF, abducent nucleus, and facial nerve fibers plus the corticospinal tract. What is PPRF? Horizontal and ventral. PPR, paramedian pontine reticular formation, which is, it is paramedian, it is pontine, it is reticular formation, it is a paramedian reticular formation. PPRF is a paramedian reticular formation. So the involvement is paramedian reticular formation is involved. That is why horizontal gaze palsy will be there towards the side of vision, ipsilateral facial paralysis, contralateral hemiplegia. The difference between this and the above one is there is a gaze palsy also added. So you have an ipsilateral facial palsy, element type, contralateral hemiplegia, UMN type of course, and then you also have this gaze palsy, horizontal gaze palsy towards the side of lesion. If you ask him to look towards left side, he will not be able to look to the left side. He has got a left-sided lesion. That is called the Fauvel's syndrome. Now, go to the AICA syndrome. That is called the anterior inferior cerebral artery. Infarct the anterior inferior cerebral artery. Anterior inferior cerebral artery syndrome, ipsilateral facial paralysis, ataxia from the cerebellar peduncular involvement, vertigo tinnitus because of the eighth nerve involvement. Okay, AICA territory is facial nerve paralysis, ipsilateral facial nerve paralysis. There is no hemiplegia here because the fibers are not there, and ataxia and cerebellar involvement will be there. Tinnitus and acute loss of hearing may be there. That is called the AICA. Now you have got the locked-in syndrome. What is locked-in syndrome? Usually to bilateral ventral pontine infarction due to basilar artery thrombosis. Okay? Basilar arteries in the basilar groove on the ventral part of the basal part of the pons, which is abutting the base of the skull. And there, the basilar artery, if it gets thrombosed, then you get both the sides are affected. Then what will happen? Quadriplegia will be there. Anarthria is not able to construct any speech. Anarthria due to interruption of the corticospinal and corticobulbar tracts. Preserved consciousness, vertical eye movements as reticular formation, and midbrain vertical gaze centers are spared. There is no involvement of the vertical eye movement. There is no involvement of the reticular formation. Gaze paralysis is not there. A quadriplegia is there. Anarthria is there. It is a locked-in syndrome. Or why it is called locked-in? Any idea? Because both he has got all the limbs are locked like that. So it's called locked-in syndrome. Okay. Now, what are the syndromes? Now go back and I'm reviewing. First start with the Pontin things. What are the 3 Pontin syndromes? Millard-Gubler syndrome.
Millard-Gubler syndrome.
Ventral pons is involved. Okay. Ipsilateral
Ipsilateral with the contralateral
hemiplegia. Millard-Gubler syndrome. Okay. Foveli syndrome.
Contralateral hemiplegia, ipsilateral fascia palsy. There is also
gaze palsy. AICA syndrome.
AICA, there is
ipsilateral phase, ataxia cerebellar tinnitus of the 8th nerve. Locked-in syndrome, quarter. Okay, we got. Now go to the. We now go to medulla. Anarthria. This is difficult. Arthria is speech. Anarthria, no speech at all. He is conscious. He knows. If you ask him to read, he will read. All the cerebral part of the speech is there, but the peripheral mechanism of speech is not there.
Completely is not able.
Not able to speak. It is not aphasia. Aphasia fellow, if you ask him what is your, he does not know how to even generate the speech. Here speech is generated in the brain, but it's not able to come. Anarthria, lack of speech. It is something like dysarthria, anarthria. Dysarthria is one side, anarthria is total. Both sides are affected. It is not aphasia. Okay, not like Broca's aphasia. Okay, medial medulla. Medullary syndromes are medial medulla, lateral medulla, like that. Medial medullary syndrome, also called the disarranged syndrome. That is, medial part of the medulla is affected, usually infarction of the anterior spinal artery and penetrating branches of the vertebral artery. Structures are corticospinal pyramids are involved, medial lemniscus is involved, hypoglossal nucleus is involved. Automatically, corticospinal involved. What will happen? Contralateral spastic hemiparesis. Medial lemniscus is involved. Medial lemniscus carries vibration and proprioception sensor. So, contralateral proprioception and vibration is lost. And then hypoglossal nerve is involved. Ipsilateral lower motor neuron type of the hypoglossal falls the tongue towards the lesion. Now you describe medial medullary syndrome.
Contralateral hemiplegia.
Because of the pyramids are involved. Because of the involved, it is higher before the decussation. This is before the decussation. That's why it is contralateral. Okay, along with the pyramids, there is another structure that is there. That is the medial lemniscus, very close to the pyramid. That is also contralateral. Now, very close to that is the 12th nerve nucleus, hypoglossal nucleus. That hypoglossal nucleus paralysis produces ipsilateral tongue paralysis. What will happen? Tongue will be pushed to the same side of lesion. And also it will be atrophic, it will be showing fibrillation and then fasciculations. So there will be a lower motor neuron type of involvement of the tongue with fibrillations and fasciculations of the tongue, wasting of the tongue and tongue towards the side of lesion. Is a hypoglossal on the same side, contralateral hemiplegia and also medial lemniscus involvement. Pyramidal involvement hemiplegia, medial lemniscus involvement produces proprioceptive sense. So teasing, then you have got, this is called the medial medullary syndrome or medullary hemiplegia, medial disarranged syndrome. Lateral medullary syndrome, very classical. Wallenberg syndrome, most often by posterior inferior cerebellar artery or vertebral artery occlusion. Structures involved, nucleus ambiguous, NTS, dorsal motor nucleus, so the DMNS, the dorsal motor nucleus. Okay, vestibular nuclei, spinal segment of the nucleus and tract, spinal thalamic tract, inferior cerebellar peduncle, and descending sympathetic wave. Last time I have told you what are all these things. What will happen? Because of the involvement of the nucleus ambiguous, dysphagia and dysphonia. What is nucleus ambiguous? It is the motor nerve of the pharynx and larynx. Motor nerve of the pharynx and larynx is ambiguous, nucleus ambiguous. Because of that, you will have dysphagia and dysphonia, and also absent gag reflex. Okay, NTS. NTS is what? NTS is the sensory part of the visceral sensations. It is the visceral sensations are caused by the NTS. Okay, and then dorsal motor vagal nucleus is the motor nerve of the viscera. It is the motor nerve of the viscera. Okay. And then the ipsilateral facial pain and temperature loss, contralateral this one. Why that is lost? Because of the spinal trigeminal nucleus and tract. That's why ipsilateral facial pain and temperature loss, and also contralateral pain and temperature loss because of the spinothalamic involvement, contralateral pain. And this is called crossed sensory plegia. And not hemiplegia, crossed sensory hemiplegia. Okay, sensations, pain and temperature, dissociated hemiplegia. Pain and temperature on the contralateral side, ipsilateral face side, same side, pain and temperature. Absence of gag reflex, dysphonia, dysphagia, and because of sympathetic fibers, Horner's syndrome. Okay, and because of the cerebellar peduncle, nystagmus and limb ataxia will be there. Okay. This is a feature of lateral mandibular syndrome. Very extensive involvement. What are all the things involved? Nucleus ambiguous, dysphagia, dysphagia, absent gag reflex. NTS is the sensory nerve of the viscera, and dorsal motor nucleus is the motor nerve of the viscera. Vestibular nuclei because of that imbalance. Spinal trigeminal nucleus, ipsilateral pain and temperature on the face. Spinothalamic, pain and temperature on the opposite side. Inferior cerebellar peduncle, because of that there will be nystagmus, limb ataxia, and because of the sympathetic fibers, Horner's syndrome. Okay. Now, there are some specific nuclei. We need to know about this nuclei. I'm bringing for your memory. Nucleus ambiguous. It is the motor nerve of the pharynx and larynx. If it is paralyzed, dysphagia, nasal regurgitation, absent gag reflex, dysphonia, all are deviated away from the side of lesion. NTS is nucleus tractus solitarius. This is the motor nerve of this is the sensory nerve of the viscera. Like impaired baroreflexes, autonomic instability, loss of taste also is there. NTS, posterior 1/3 of the tongue taste also is affected with that. And dorsal motor nucleus of the vagus, DMNV, is a motor nerve of the viscera. The cardiac rhythm, gastrointestinal motility are dependent on it. Hypoglossal nucleus, ipsilateral lower motor neuron, tongue palsy, dysarthria, inferior olive, delayed contralateral cerebellar signs, possibly palatal myoclonus. Olive is important for the cerebellar connections. Inferior cerebellar peduncle, ipsilateral limb ataxia, and dysmetria. What is dysmetria? Not able to measure the distance. Suppose you ask him to the finger pointing. Either he will overshoot or he will stop before. It's called unable to measure the distance. Okay, dysmetria. Now, spinal cord versus brainstem. When do we think of a spinal hemiplegia? Hemiplegia without any cranial nerve. Hemiplegia without any cranial, not only facial. You can correct it as any cranial nerve. Facial, cranial nerve. Because if it is cranial nerve involvement, it is not for spinal hemiplegia. No cranial nerve involvement. There is a sensory level. In a spinal hemiplegia, patient will say, sir, below this I am not feeling the sensation. Sensory level will be there, a transverse level. And bladder involvement is very early in spinal hemiplegia. Whereas in the brainstem or other hemiplegias we have seen, bladder and bowel are spared. Okay, how do I differentiate brain, brainstem, spinal cord? These are the three areas, mainly. Brainstem has got, of course, midbrain, pons, and medulla. Brain has got cortical and the internal capsule, and the spinal. Brain, brainstem, spinal cord. Facial involvement, brain yes, brainstem yes, spinal cord no. Cranial nerves involvement, brain no, because there are no cranial nerves in the cortex there. Brainstem yes, spinal cord no. Sensory level no, No, in brainstem and brain, it is there definitely in the spinal cord. Bladder, not involved in the other two, not in this. Very easy for you to understand this way. Okay? Now, acute versus chronic hemiplegia. So, temporal clues, that is time clues. Patient says the hemiplegia has developed over a period of 2 months. Okay, sir, it started slowly, upper limb I'm not able to use, and lower limb also, now I'm not able to totally use. That's a chronic hemiplegia. Versus, I was all right, sir, in the market, I was just crossing the road, suddenly I felt one part. That is the acute hemiplegia. Stroke, intracerebral hemorrhage, brainstem infarct are the acute onset. What are the three types of involvement? Embolic, thrombotic, hemorrhagic. Okay, so the infarction is thrombosis, embolism and embolism and thrombosis are infarct. Hemorrhage is bleed. So there are hemorrhagic stroke, infarction stroke. Just like myocardial infarction, cerebral infarction. Under cerebral infarction, again two causes. Instantaneous embolism. A little time is there, thrombosis. Hemorrhage, lightning, very fast because it occurs. This is the difference. The speed of occurrence, hemorrhage is the fastest, infarction, embolism is the next faster, and comparatively slower is the thrombosis. Whereas subacute or chronic involvement, you have to consider three important things. Could be a tumor, could be a cerebral abscess, could be demyelination. Tumor, abscess, demyelination. Then putting all these things together for you. Now, patient has come with hemiplegia. Are there upper motor neuron signs? Yes. That means it is a central lesion above the decussation. It is not anterodorsal. Is the face involved? Yes. Means above pons. Okay. Face is not involved. Spinal cord. Cortical signs are present. Yes. Cortex. No. Internal capsule. Cranial nerve paralysis ipsilateral present. Brainstem. No. Internal capsule. Which nerve is involved? Third nerve, midbrain. Seventh nerve, pons. 12th nerve, medulla. Very simple now. Now, examples. Sudden onset of right hemiplegia. See that. Sudden onset of right hemiplegia. Dysarthria, no aphasia, no sensory loss. Which is okay. What is the case? It is a vascular event. Okay. Right hemiplegia. Lesion must be on the left side. Okay. Hemiplegia is dense. Internal capsule. There is no aphasia. It is not cortical. No sensory loss. Not cortical. Dysarthria. Peripheral problem. It's not aphasia. So it is an internal capsule. So internal capsule infarct. Answer. Now case 2. Right hemiplegia, right facial UMN, expressive aphasia. Right hemiplegia, aphasia is there. The moment there is aphasia is there, right hemiplegia means left cerebral cortex is in. That is why he has developed this one. Upper motor neuron type of facial paralysis, because face also is affected there. So more in the face region, expressive aphasia. Okay. It is not lower motor neuron face. Lower motor neuron face means you come down to the pons. So the expressive aphasia means he recognizes, but if you ask him to what is 2 into 2, he will write and show you, but he cannot say 4. If you say what is today's date, he will not say today's date is 17th. He will not be able to say, but if you ask him to write today's date, he will write. This is called the expressive aphasia. Okay. So what is the lesion? Left middle cortical stroke. Left MCA stroke. Left middle cerebral artery stroke. Now, case 3. Left hemiplegia, right ptosis and dilated. ipsilateral third nerve, contralateral hemiplegia. Means what? Third nerve is Weber syndrome. Third nerve, Weber syndrome. Right midbrain, Weber syndrome. Then, okay. Now, one line examiner answer. Hemiplegia with spasticity and exaggerated reflexes indicates a supranuclear lesion. So, somebody has come with spasticity and then exaggerated jerks. That means it is upper motor. Supranuclear means above the anterior heart cell. I first assess the facial movement to differentiate between suprapontine and the spinal lesion. Then I look at the cortical signs as aphasia or neglect to identify cortical involvement. If cortical signs are absent and face, arm, leg are equally affected, then I am in the internal capsule. If the ipsilateral cranial paralysis with contralateral hemiplegia, the lesion is somewhere in the brainstem. Specific level is identified by the cranial nerve affected. If third is affected, it is midbrain. Seventh is affected, it is pons. 12th is affected, it is in the medulla. Okay. A flow chart. How do you go about diagnosis? Step 1, patient presents with hemiplegia. What is the step 1? Is it upper motor neuron or lower motor neuron? First one. What is upper motor neuron? Spasticity, hyperreflexia, extensor plantar, no fibrillations, no fasciculation. Upper motor. Is face involved? Next question. Yes, the lesion is above the brain, above the pons, maybe brain. No, think of spinal cord. Okay. Step 3. Are higher cortical functions affected? Yes. Aphasia, apraxia, neglect, seizures, sensory, visual defects are there. Hemianopia, if it is affected, it is cortical lesion. If it is not affected, subcortical. Then, is there ipsilateral cranial nerve paralysis? If it is there, brainstem, crossed hemiplegia. No, it is internal capsule. Which cranial nerve? Third cranial nerve, midbrain. Fifth cranial nerve, seventh cranial nerve, pons. 12th cranial nerve, medulla. Okay. Hemiplegia plus aphasia plus neglect is there. The cortex. Then you have dense hemiplegia, no cortical signs. You have got is the dense hemiplegia internal capsule, ipsilateral third nerve paralysis, contralateral hemiplegia brain, ipsilateral LMN and contralateral hemiplegia facial nerve, pons, tongue LMN and contralateral hemiplegia medulla, hemiplegia without face and nerve and has a sensory level. It is spinal cord. Any number of ways I have drilled you, they may say. Now, some MCQ questions. Now, read it. 62-year-old man presents with sudden right side hemiplegia. All are equally involved. There is only dysarthria, no aphasia, no neglect, no sensory loss. Where is the lesion? Which is right side hemiplegia, left internal capsule. The answer must be left internal capsule. B is the answer. Okay. Now, dense pure motor stroke is the explanation. MCQ. Patient has left hemiplegia with right-sided ptosis, dilated pupil, eye deviated toward out, down and out. Means what? Right-sided ptosis, ipsilateral third nerve. And then left-side hemiplegia contralateral. Means what? Weber syndrome. Isn't it? Ipsilateral third nerve, contralateral hemiplegia. So where is the lesion now? It's in the right midbrain. Isn't it? So B is the answer. Now go to the MCQ 3. Presence in the hemiplegia, sparing face, early bladder involvement. Sensory level is there. Spinal hemiplegia. Okay? Spinal cord. Answer is spinal cord. Question 4. Expressive aphasia, UM and facial pulse. Where is it? Left middle cerebral artery involvement, cortical involvement. So that's why aphasia is there. Left MCA, because right side hemiplegia, left this one. MCQ 5. Ipsilateral tongue deviation with contralateral hemiplegia localizes the lesion to medial medullary syndrome, isn't it? Tongue deviation is there, hypoglossal is there, it is in the medulla, deviation to the side of lesion, and it must be medial medullary syndrome, also called the Deserine syndrome. Okay? How you have to analyze several things. How will you localize the lesion in a patient with hemiplegia? I will ask you in the examination. My dear, did you hear somebody talking to you for 1 hour and four, 5 lectures, priming you with all the connections about that, and ultimately he has told you, he is my friend. Now you tell me how you localize the lesion. Then you have to answer. Model answer. You have to, you can say. This could be the model answer for that. In a viva, if they are asked, how do you give the level of localization? Hemiplegia spasticity, exaggerated reflexes indicates that it is a supranuclear, also called the upper motor neuron lesion, sir. So I am not dealing with the lower motor. I will first assess the face. A facial involvement suggests a lesion above the pons. Facial involvement of the UMN type. Facial involvement of the element type suggests it is in the pons. Whereas pairing the face points to the spinal cord. Next, I look for cortical signs like aphasia, neglect, seizures, hemianopia, and these indicate it is a cortical lesion. Usually the hemiplegia is not dense. It is sort of distributed and one part is more affected than the other. Usually MCA territory. If cortical signs are absent, face arm legs are densely involved and equally involved, there are no sensory signs, I localize lesion to the internal capsule, which produces a pure motor. So if there are ipsilateral lower motor neuron type of cranial nerve paralysis with contralateral type of hemiplegia, then hemiplegia, it is a brainstem stroke. Third nerve, midbrain, seventh nerve pons, 12th nerve medulla. Thus, a systematic clinical examination allows precise anatomical localization. Midbrain, medial midbrain syndrome, Deserine, lateral, this one is Weaver's, Pons, Maillard Gabler, Faveli, Benedict, all those things we have seen, and medulla Deserine, Deserine and Wallenberg, spinal cord. So given you a table also. What you can do, you can see paresis pattern associated, pair, cerebral cortex. So localization clue, significance of that. Internal capsule, how it will look like. Localization clue, and the significance. Brainstem lesions, course repetition only, whatever they have told. But then it is again important for you to look at a tabular form. And then the spinal cord. And finally, you have to have what is called the CN, cranial nerve paralysis and hemiplegia, crossed ipsilateral or contralateral sensory loss, higher cortical functions. I think this is a very summary lecture on localization of hemiplegia. And this is going to be a bread and butter because this is going to, CNS case will be the main case. Mostly it will be a hemiplegia or anything, something will be put. So you should be able to, this PDF you keep and thoroughly you revise it. Last time I gave all the PDFs, videos. This video also I will give. Okay. So what else I can do? I'm putting maximum time. This one from my side. Okay.